So these are talks that I gave last year, a couple of years ago. So, but it's basically going to be some of the same information. I'll let you look at anything else you need to add in. But what we're going to do is we're going to start out just talking about some respiratory physiology. And what I always find is that when I read medical papers and everything else, they have all kinds of charts and graphs and things to look at. And it's like, they look fantastic, but what do they mean? So what we're going to try to do is figure out what things mean. And I call this one Respiratory Physiology 101. This is about the anatomy, physiology, blood gas interpretation, and some basics of mechanical ventilation. And so what we're going to try to do in this talk is we're going to try to review some of the respiratory physiology, specifically looking at blood gases. And we're going to talk about the basics of some mechanical ventilation. And then what we'll do next after this talk is we'll talk about the physiology of brain death and how brain death kind of changes basic physiology. And then following that, we'll talk about sort of more advanced strategies of looking at manipulating neurologically deceased donor lungs and trying to recruit them in the way that we want to recruit them so that they can be transplanted. And what I'll ask is that if anywhere along the way you're confused, you have questions, I'm not making any sense, which sometimes happens, then just stop me and ask questions. I'd much rather this be a dialogue. I always do better with dialogues, but I'm also happy to just keep talking until my throat gets dry. So if you guys don't stop me, I'll just keep going on my own. If I look out there and it looks like you are having these blank, I don't get it looks, I'm going to ask questions and just say, you know, do you get this? And there are some built into this talk. There are some questions that I'll ask you to kind of look at and answer, and just to break up the monotony of me just sitting here talking. Okay? Questions about anything to start with? All right. So what we're going to do is we're going to start out, we're just going to talk about how do we normally breathe. And this is when we're alive and breathing. So we normally breathe at a rate that's called R and a tidal volume called TV to meet the minute ventilation needs of the body. And minute ventilation, remember, is how you get rid of carbon dioxide. So minute ventilation is respiratory rate times the tidal volume. And that's the way we eliminate carbon dioxide and regulate our pH. We initiate breaths by negative pressure. So normally when we breathe spontaneously, our diaphragms contract, they drop down, our chest wall contracts, it pulls out. And so we create a vacuum inside and we suck air in basically. And then when we exhale, it's all passive. We just relax and everything. The stretch just goes away. And we for the most of the time, we passively expire. All right. And then we repeat this as long as it's necessary, which for most of us is our entire lives until we're no longer breathing. So ventilation is getting the bad gas out or getting rid of carbon dioxide. Carbon dioxide is a byproduct of metabolism that takes place in the body. You produce carbon dioxide, you've got to get rid of it, or it's going to alter your acid-base status too much. Oxygenation is getting the good in. That's where you get your PaO2 in. That's oxygen goes into the alveoli. We all know that what we're breathing out here in room air is how much oxygen? 20.9% to be precise. 21% is what most people will talk about. And that translates into a partial pressure. Anybody know what the partial pressure of the oxygen and ambient air that we breathe is? About 140, 135, 140. Partial pressure gas equation tells us that. It depends on how high or low you are above sea level. So if you're up in Denver, it's going to be a little bit different than when you're down here. So SATs in Denver generally tend to be a little bit lower. PaO2 tends to be a little bit lower because the altitude is lower, partial pressure of oxygen to be in level. And then the third thing that the lungs do is they provide an immunologic barrier. Remember that when you breathe in, you're really taking outside air contents in. It's really going into your body, but the lining of your lungs, all your bronchus and bronchioles and the alveoli are all in contact with the outside world. So the lungs provide an immunologic barrier to kind of protect you. Now, that's not going to be important from an oxygen ventilation standpoint, but it is important from an immunologic standpoint. So we always have to remember that as well. And that's about the last thing we're going to say about that. So the upper airway, and when I think about human physiology, I think about it a lot in terms of plumbing and electrical. So if you know anything about electricity, you know anything about plumbing, you can pretty much figure out human physiology. But so the upper airway is more of a plumbing thing. So basically, it's a conduit that exists to get air down to the working part of the lungs, which is the alveoli and the gas exchange sacs. So the upper airway consists of the nasal cavity, the nose, the larynx, the trachea, the main stem bronchi, the lobar bronchi, segmental bronchi, terminal bronchi, and the total volume of that upper airway is about 150 milliliters. So it's pretty small. Now, the lower part of the airway, that's the working part of the airway. That's where gas exchange takes place. That takes place in the respiratory bronchioles, the alveolar ducts, the alveolar sacs, and the total volume of that is about 3 liters. So if you think about it, the fact that between here and here, you've got 3 liters of gas exchange available, and that's the working part of the lungs, and that's what we rely on to exchange gas. The lower airway consists of about 300 million alveoli in the normal adult. Each alveoli is composed of predominantly pulmonary capillaries that are in contact with the outside of the alveoli. I'm going to talk more about this later. The total surface area of the alveolar surface area, if you take every alveoli and you take your little micro scissors and you cut them and then you stitch them all together and you lay them out on the floor, it's going to be somewhere around 50 to 150 meters squared, which is about the size of an average tennis court, or probably, 3 times the size of the floor of this room. So that's the surface area across which we're exchanging gas, which just seems enormous to me. And I just think it's pretty remarkable how we're packed together. But that's why we have so much reserve generally. And then the alveolar surface and the pulmonary capillary interface is where the gas exchange takes place. So oxygenation and ventilation are the result of sort of coordinated interactions between the central nervous system, the respiratory system, the cardiac system, the musculoskeletal system. And you get input from the receptors in the body that are sent from the respiratory centers of the pons and the medulla. And that tells you what you need to do. And the output is through the vagus nerve, the phrenic nerve, the intercostal nerves. And this all works really well as long as the computer that runs the body is functional. That's the brain. But once the brain stops working, all of this stuff stops working as well. So gas is conducted through the large airways to the small airways where the gas exchange takes place. If we look at the sort of a cartoon caricature of what this looks like is you've got the pre-exchange. So this is your pre-exchange here, where you've got your CO2 is 46, your O2 is about 40, and your saturation or SbO2 on the venous side is somewhere in the 65 to 75% side normally. And then you've got your alveolar gas that we already talked about, where the partial pressure by the time it gets down into the lungs and into the alveoli is about 100 to 110. And that's what you have driving the oxygen going across the alveolar capillary membrane. It's the difference between this 101 and this 40 that drives the oxygen across that capillary membrane into the bloodstream. And that's how we get oxygen into the bloodstream. So anything that affects this interspace or the ability of the gases to get down into the alveoli is going to affect the ability of gas exchange. So anything that causes either fluid or pus to accumulate in the alveoli, and I've got some pictures of this later, or this space in between the two, which is called the interstitial space. So when you hear people talk about interstitial pneumonia as opposed to alveolar pneumonia, they're talking about where you get inflammation in this space in between the capillary and the alveoli. And any pus that gets in there, anything that fills up that space is going to stop the diffusion of gas across it or slow the diffusion of gas across it. So you can imagine if you have somebody that's got a pneumonia here in the alveoli, when they take a breath, what are you going to hear? You're going to hear things bubbling in the alveoli. So you're going to hear crackles. When it's in the interstitium between the alveoli and the capillary space, what are you going to hear? Yeah, you don't really hear much of anything. So people can have pneumonia, and that's one of the ways you can tell the difference between a capillary pneumonia or an alveolar pneumonia and an interstitial pneumonia. But either way, you're going to affect that gas exchange. And so the gas exchange is proportional to the surface area of the membrane, which we already talked about, the diffusion coefficient of the gas across that space, the concentration gradient between the two sides of the membrane, and the pressure differences between the two sides of the membrane. And the ones that we take most advantage of with a ventilator are concentration gradients, where we can jack up the oxygen to 100%, and pressure gradients, where we can create a positive pressure gradient instead of a negative pressure gradient. But we can push from the alveoli towards the capillary and force gas across there by giving more pressure. All right. And that's what a mechanical ventilator does. The gas exchange is also inversely proportional to the thickness of the membrane or the distance between the two areas like we talked about. So the factors that affect the gas exchange and the rate of diffusion we've talked about, and then the gas exchange itself. So you've got oxygen that moves from an area of high concentration to an area of low concentration. You've got carbon dioxide that moves from an area of low concentration to an area of high concentration. And this is what drives the gas across. If you look at the relative diffusion coefficients of different gases, and the ones we're talking about are carbon dioxide and oxygen. Which one do you think moves across the alveolar capillary interspace better, oxygen or carbon dioxide?
Oxygen.
Yeah, carbon dioxide does actually. Carbon dioxide is a smaller molecule and is shaped differently, and it actually can move across the membrane in a much easier way. So it actually has about a diffusion coefficient about 20 times that of oxygen. So when you have somebody that actually goes into respiratory failure, the typical thing that would happen when you go into respiratory failure is the first change you see is in your carbon dioxide level. And usually the first change you see is your carbon dioxide level goes down, right? So you start to hyperventilate to try to get more oxygen in. And your carbon dioxide, because it can more effectively cross that membrane, actually goes down. Then as you go into respiratory failure, the carbon dioxide level starts to go up and the oxygen level starts to go down. Okay? And that's what you see in somebody that's having an asthma attack. That's what you see in somebody that's got a pneumonia that's just starting. They start working harder to breathe. They can effectively get rid of carbon dioxide to support the oxygen up to a point, and then they go into failure. All right, so oxygen delivery, the DO2 that we talked about, is
Made up.
it's made up. I just made it up. So oxygen delivery is actually the oxygen content of the blood times the cardiac output. And when you look at the oxygen content of the blood is divided into two different things. It's the amount of oxygen you can get that can get dissolved in plasma, and it's the amount of oxygen that can get bound to oxygen or bound to hemoglobin, right? And which do you think carries more? You think you dissolve more oxygen in plasma, or do you think you bind more to hemoglobin? Which is why we have hemoglobin. So you can bind much, much more oxygen to hemoglobin. And that's why the oxygen saturation is actually the most important part of this equation, not the partial pressure of oxygen. So if you look at this equation, it'll tell you, and these are just numbers, but this is the number of grams of oxygen bound per gram of hemoglobin times the arterial saturation, plus the dissolving coefficient of oxygen in plasma, which is 0.0031 times the partial pressure of oxygen. Okay, so the amount of oxygen that actually gets bound to hemoglobin and carried by hemoglobin is much, much higher. And then you multiply that by the cardiac output, and that gives you your oxygen delivery to all your body organs. And that's why oxygen delivery becomes an important thing to think about, because that's what we're trying to maintain as we support donors. Right? So carbon dioxide can get transported in three forms. It either is dissolved in plasma, or it's dissolved as carbon dioxide, which is a small percentage of it. It's dissolved in plasma as bicarbonate, which is the majority of it, or it's actually bound, a small amount of it's bound to hemoglobin as carboxyhemoglobin. But the majority of it is transmitted into bicarb and goes back and forth between H plus and bicarb to regulate your pH. And that's part of how we regulate our normal pH in the body, that just moves back and forth as we need to. So again, the functions of the lung, ventilation is getting the bad gases out, and we regulate our breathing, the majority of us, to keep our CO2s in the 35 to 45 range, unless we develop COPD, and then it stays higher. We calculate that by looking at the respiratory rate times the tidal volume, and that's minute ventilation. And I saw you guys have in your donor management guidelines ways to calculate your minute ventilation and adjust the ventilator based on that. But this is the reason that we do it this way. And then oxygenation is getting the good gas in, and we already talked about it. The normal PaO2 is somewhere between 80 and 100 or 85 and 100. The normal saturation is between 97 and 100%. And it's created by both the FiO2 gradient and the pressure gradient that we create with negative pressure. And then when we're ventilating somebody, we do this with positive pressure. The gas exchange only takes place at the alveolar level. And when the system doesn't work well, you have respiratory decompensation. So the management goals of mechanical ventilation are to make sure we're providing adequate oxygenation, but we want to avoid oxygen toxicity. We want to provide adequate ventilation, but we want to avoid volume trauma. We want to avoid barotrauma. And then we want to evaluate the adequacy of oxygen and ventilation by looking at blood gases. Everybody know when you get oxygen toxicity? When your oxygen is above what level?
7.
So I'm talking about how much oxygen you're actually giving somebody. So if you put somebody on a mechanical ventilator and they're on 100% oxygen, there is a certain amount of oxygen toxicity associated with that. You know at what point you stop having oxygen toxicity? When you get your FiO2 down to what? Yeah, 40% or less. So if you work in an ICU, and I don't really, so how many of you are respiratory therapists? Perfect. How many of you are ICU nursing staff? And are any of you any EMTs or paramedics or any other?
Scrub tech.
Sorry?
Scrub tech.
Scrub tech, perfect. All right, so when we start thinking about it, we start thinking about oxygen toxicity gets worse when you get above 40%, and it gets irreversibly worse when you get above 60%. And it doesn't take that long for you actually to start getting oxygen radical formation. And you know what oxygen radical formation causes in the lungs, to the lung tissue?
Tension. Or
Causes pulmonary fibrosis. So it actually starts causing scarring in the lungs down, which is why we don't leave patients on 100% oxygen for days at a time, or even hours at a time. Try to get them off of 100%. Our first goal in the ICU is to get them down to 60%. Our next goal is to get them down to 40%. Once we're at 40%, we're happy and we just let them be until they get better. But we work real hard to try to avoid oxygen toxicity while we're also avoiding the other toxicities of the ventilator, which are volutrauma and barotrauma. So volutrauma, well, let's talk about barotrauma first. So barotrauma is what? So baro is pressure, so it's pressure-induced injury to the lungs. And when we think about the pressure that you're exposing the lungs to, we think about the pressure as being a high-end pressure, a low-end pressure, and an average pressure, right? The high-end pressure we call what? PIP, the peak inspiratory pressure. The low-end pressure we call the PEEP, or the peak end expiratory pressure. And then the average pressure we call the mean airway pressure. So those are the three pressures that we look at when we look at the mechanical ventilator and when we think about the physiology. So which of those do you think is most likely to cause pressure-induced injury in the lungs? The high end pressure or the PIP? Yeah. And what kind of pressure does it cause? Or what kind of injury does it cause? Sorry.
like you rock the lungs.
Like pneumothorax.
Yeah. So I'm a pediatrician, so it's easy for me. I think about pressure starts with P. P is pop, and you can pop the lungs, and you can pop the lungs into any space next to the lungs. So you can pop the lungs outside of the lung into the thoracic cavity. We call that a pneumothorax. You can pop the lungs down into the abdomen, pneumoperitoneum. You can pop it into the pericardium, we call it pneumopericardium. Or you can pop it into the tissues, or pop it into the mediastinum, pneumomediastinum, or pop it into the tissues, and that's the one we have to call something different. So that's subcutaneous emphysema. But all of those, that gas is popping out of the alveoli into an adjacent structure and creating pressure-induced trauma or barotrauma. Do you know what pressures you start getting at risk for having barotrauma when you're looking at your peak pressures?
30.
That's greater than 40.
So most people say somewhere between 35 and 40, you start being at risk. Greater than 40, everybody worries about. Greater than 30, we worry about in neonates. That's where they sort of don't like their pressures above 30, but that has a difference to do with their lung physiology. Now, in terms of donating lungs, that's not what we aim for. But in terms of trying to make sure we have adequate oxygenation, we can go up to pressures of 35 or so without too much concern in most patients. All right. And that's in terms of the peak inspiratory pressure. The other pressure that can cause pressure-induced lung injury is the mean airway pressure. And the mean airway pressure generally causes pressure-induced lung injury somewhere around 25-ish. So we like to keep our maps less than 25. And then PEEP really doesn't seem to cause much pressure-induced injury. And so you can dial your PEEP up pretty high without causing too much pressure-induced injury in terms of popping the lungs. It has other physiologic implications, and we'll talk about that then a little bit too. Any questions about pressure-induced injury? And then the last one we're going to talk about is volume-induced injury or volutrauma. And volutrauma causes what kind of damage to the lungs?
Makes them too stretchy.
Makes them too stretchy. Okay. Yeah, no, that's right. I mean, that's exactly what it is. So when I was training 100 years ago, when I was in medical school and residency, we didn't really know about volutrauma. We thought you only had either pressure-induced trauma or you had oxygen-induced trauma. But these guys did these really good experiments. Well, I shouldn't say guys, these ladies and gentlemen, because I don't know whether they were men or women. But they did these nice, really simple studies where they took smooth muscle cell from a dog and they put it on a petri dish. And they put the petri dish in a pressure chamber. And they turned the pressure chamber up. So normal atmospheric pressure is 1 atmosphere of pressure. That's what we're all living in now. But they took it from 1 atmosphere to 2 atmospheres to 5 atmospheres to 10 atmospheres. And they looked to see if there was anything going on at the molecular level in these smooth muscle cells that said these cells were under stress. And they were just laying there happy as clams, not doing anything. But then they took those same smooth muscle cells, they took the pressure down to 1 atmosphere of pressure and they stretched them. And they just pinned it down stretched. And then they looked to see what happened. And all of a sudden, it started churning out messenger DNA and messenger RNA that basically was laying down fibrotic tissue. And so it was on the basis of really simple experiments, but very elegant, that they said the thing that causes pulmonary fibrosis is not pressure, it's stretch, just as you said. And so that stretch injury occurs usually when you get above about 10 per kilo of tidal volume. So again, when I was a resident, we used to take people 12 to 15 per kilo of tidal volume was very common. That's the way we used to ventilate everybody. But then when we got smarter, we said, okay, that's dangerous. So we took it down to 10 to 12, and then we took it down to 8 to 10. And then we took it down from there to 6 to 8. So most people now recommend using 6 to 8 cc's per kilo of tidal volume based on ideal body weight. Okay, not based on actual body weight, but ideal body weight. All right, and that way you avoid the volume-induced injury or volume drop. All right, questions about that? Does that make sense? And that's what we're going to end up targeting when we get down to the mechanics of the ventilator. So now let's just talk a little bit about blood gas analysis. And so what blood gas analysis does is, I'm 1 slide behind, I'm sorry. If I'm talking about something that's not up there, just let me know. Because on here, I'm seeing it this way, but it tells me what my next slide is, and I don't even know what my next slide is. So blood gas analysis is we do to tell us how efficient the gas exchange is occurring. And typically when you want to look at the integrity of the gas exchange in the alveoli, what kind of blood gas do you want to look at? Well, what are the different kinds of blood gases you can do?
Venous and arterial.
Yeah, so you can do a venous, you can do an arterial blood gas, or you can do a venous blood gas. You can do a peripheral venous blood gas, you can do a central venous blood gas, you can do a capillary blood gas, which, we just prick people's fingers and we look at blood and it's not the capillary bed. Capillary blood gas actually comes from the fact that we collect the blood into a capillary tube. Okay, and the respiratory therapists here that have done that know you take these little fine capillary tubes, you pull the blood up into it, you put a little bead in it that's got heparin on it, and you have a magnet that takes the bead back and forth, and you end up putting that into your blood gas machine. So that's a capillary blood gas, but it's not really measuring what's going on at your capillary level. We can't do that. But what it does is it measures what happens when you macerate a fingertip with a sharp object and you have some mixture of arterial and venous blood that's coming out of there. So typically when we do that, we arterialize, or we warm up the extremity first. That dilates it out and causes more of it to be arterial. So we think that's a better measurement of what's actually going on. But those are the different kinds of blood gases that you can use. Typically, we ideally like to look at, if we're looking at the function of the lungs, we want to look at what kind of blood gas is going to best reflect that.
Arterial.
Arterial blood gas. So that's what we would use as our hallmark. Now, in critical care medicine, we also use mixed venous blood gases or central venous blood gases. And we primarily look at that to look at what's going on in the tissue body, the tissues of the body and the organs of the body to tell us whether we have adequate oxygen delivery, getting back to our oxygen delivery equation. Okay. But that tells us if we're delivering enough oxygen to the body, and we can tell that by looking at how much oxygen is being extracted from the hemoglobin. So if you're desaturating your venous, so we said normal venous saturation is 65 to 75%. But if your saturation on a venous blood gas, central venous blood gas, comes back at 40%, you know that you're not delivering enough oxygen to those tissues because you're having to over-extract way beyond what the normal range is from the hemoglobin in order to get adequate oxygen delivery. And that's a setup for developing hypoxic injury to your lungs. So some people are up to your organs. So some people will actually follow mixed venous blood gases. Certainly in the ICU setting, we do all the time, but even in the organ donor management setting, sometimes we'll follow those to make sure that we're delivering adequate amounts of oxygen. Even if our arterial blood gases look okay. And sometimes we follow mixed venous. Do you guys ever look at mixed venous blood gases at all?
No.
Yeah.
No, we don't.
Yeah, I would say not a lot of people do, but some people will look at it, especially in a tough case where they're trying to figure out why somebody's lactate continues to rise. Because if their lactate's continuing to rise, it tells you they're shifting from oxygen-driven metabolism to non-oxygen-driven metabolism, or anaerobic metabolism, and that makes us worry about not having enough oxygen in the liver. So it's just one of the things you can use in specific cases, where you're trying to figure out why somebody's lactates continue to climb in a donor management setting. Okay. All right, so blood gas interpretation, and then this graphic just sort of tells you where you can pull a blood gas from. But remember that if you, no matter where in the arterial system you pull a blood gas, whether it's from the radial or whether it's from a central artery, all of the blood gases should look about the same because you're not extracting any gases out of the arterial system until you get to the capillary bed. So as long as you're in an artery, it doesn't matter whether it's in the foot or in the arm or in the groin or in the neck, the arterial blood gas should look about the same. The venous blood gases are very different than that. We've already talked a little bit about the differences. The ideal mixed venous blood gas comes from the pulmonary artery, but we rarely have pulmonary artery catheters in place anymore. And so we'll do a central line that's in the same place where we can do serial samples and get an idea of what the trend is in terms of oxygen consumption. All right, so blood gas interpretation. So remember that when you look at a blood gas, it consists of a pH, a PCO2, a PO2, a bicarb, a base excess, and a percent saturation. Of those, the pH, the CO2, and the O2 are measured directly, and the rest of them are calculated based on that. So if your pH is off, your saturation may not be right. If your CO2 is off, your base excess and your bicarb may not be right. If your pH is off, the same thing is true. But it's just important to know what's actually measured and what's calculated. If you really want to look at the amount of oxygen in the blood itself and you want to measure the saturation, you can do what's called a co-oximeter panel. We used to do those in burn patients. If any of you are familiar with that, that actually gives you a direct measurement of everything that's bound to hemoglobin. Okay, but the blood gases we use generally are not like that. We measure the pH, the partial pressure of oxygen, partial pressure of carbon dioxide. Then those other ones are calculated, and that calculation shifts based on the temperature, based on the pH, and based on an enzyme called 2,3-DPG, which is not important for you guys to know, but just so you're aware, those things are calculated, not directly measured. Normal blood gases, we've talked about this briefly, but normally your pH should be 7.35 to 7.45. Your partial pressure arterial CO2 should be 35 to 45. Your bicarbonate should be 22 to 26. And your saturations, your PaO2 should be 80 to, the partial pressure of oxygen should be 80 to 100. And your saturation of our oxygen should be 98 to 100% normally. With a PVO2 or partial pressure of venous oxygen of 35 to 45 and venous saturations of 65 to 75%. Questions about any of this? That all makes sense to everybody? Okay. So then how do we start breaking it down? Well, anything that's a pH of less than 7.40 is an acidosis. Anything that's a pH of greater than 7.40 is an alkalosis. It's real simple. 7.40 is the right answer. Anything else is wrong. Bicarbonate, anything less than 22 is an acidosis. Anything greater than 26 is an alkalosis. So if we look at respiratory acidosis, that implies that we have increased CO2 retention. Our pH is less than 7.40 and our CO2 is greater than 45. Our bicarbonate, if it's uncompensated, will be in the normal range, 22 to 26. And if it's partially or compensated, then it will be greater than 26. And an example of this would be somebody that's got any kind of CNS depression on board, or somebody that doesn't spontaneously breathe on their own and you've got their ventilator set wrong. Anybody that's got asphyxiation or some kind of obstruction, and anybody that's hypoventilating for any reason. Questions about that? That's respiratory acidosis. Respiratory alkalosis is where you have CO2 retention. That's where your pH is greater than 7.40. Your CO2 is less than 35. Your bicarb, again, is going to be in the normal range if it's uncompensated, and it's going to be less than 22 if you're trying to compensate. Metabolic acidosis is where your pH is less than 7.4 and your bicarb is less than 22. Your PCO2 is going to be in the normal range if it's uncompensated, and if you're trying to compensate, it's going to be less than 35. And then metabolic alkalosis is going to be pH of 7.4 with a bicarb of greater than 26. Your PCO2 should be in the normal range, 35 to 45 if it's uncompensated, and greater than 45 if you're trying to compensate. I think the important things here are that some of the causes of this can be excess vomiting or excess gastric suctioning, because you're pulling off acid out of the stomach And so you can actually develop an alkalosis. So occasionally we'll have this happen with neurologically deceased donors because we've got all their NG tubes hooked up to low intermittent suction. Okay, and then also diuretics can cause this, and mineralocorticoids, two drugs that we commonly use as well in our population. And so we just have to be aware of that and we have to compensate for that. So how do we interpret a blood gas? The first thing we do is we label the pH. The second thing we do is we look at the CO2 and the bicarb in relationship to the pH. And then we compensate, we check for compensation, either partial or complete. And then we consider the possible causes of the acid-base disturbance. And then, you know, these pictures, which you can find on the internet, these are just diagrams that talk about which category does it fall into. And you can download these, and they're really simple. And I don't know, you guys have calculations that you use for this. I think the diagrams are nice because you just look where the CO2 is and you look where the pH is and you put your dot there and you say what it is. So these are easy to use and you can download these. So we know that there are significant interactions between the heart and the lung. We know that you provide adequate oxygen delivery, and this is what we talked about before. So oxygen delivery is this big equation here. And then oxygen utilization is the same equation, except you substitute in SVO2 here and PVO2 here. And that tells you how much oxygen your body is actually extracting and how much the tissues are using. And as we talked about before, you can use that to try to tell you whether you have adequate enough oxygen delivery. All right, so here's the first question for you. With concerns about a dislodged endotracheal tube, which of the following would provide the most reliable indicator that the tracheal tube is in the trachea of your patient or your donor? And you guys can just read them and tell me what your answers are. So is it going to be the presence of equal breath sounds over the lungs on auscultation? Just raise of hands if you think that's the right answer. Is it going to be the presence of water vapor in the tracheal and endotracheal tube? Is it going to be the absence of breath sounds over the abdomen? Or is it going to be the presence of exhaled CO2 after 6 breaths as determined by a colorimetric device?
D would be the most reliable.
The answer, yeah, the answer is going to be D. All right, so if you're taking it, so 4 hours of, wait a second. The correct answer is going to be D. The patient has a perfusing, if the patient has a perfusing cardiac rhythm, then you can rely on the exhaled CO2 as a sensitive and specific indicator. Do you guys have ventral CO2 monitoring on all of your donors?
No, we don't.
Sorry?
I always try to ask for something.
Yeah, I mean, I have it built into mine because I can do ventilator manipulations by looking at end-tidal CO2, so I don't have to wait for blood gases and I don't have to do a ton of blood gases. So I'll do a lot of my ventilator manipulations based on my end-tidal CO2 monitors, and that gets me moving a lot quicker in terms of managing the ventilator. So I try to get end-tidal CO2 monitors, but they don't always have them available, and you have to work with what you got. But I like to use them if you can. The one problem is going to be, obviously, if somebody has a cardiac arrest, they don't have circulation, they're not going to have an end-tidal CO2 reading. But this is also a way where you can tell whether or not the endotracheal tube is in the airway. If you don't have an end-tidal CO2 reading and their heart's beating, your endotracheal tube's in the wrong place. So it's one of the troubleshooting ways to do it. Let's see. Next, 4 hours after taking over a donor suddenly deteriorates. Rapid cardiopulmonary assessment reveals weak pulses and a poor color. Breath sounds are absent over the right chest. Oxygen saturation is 80% and falling. The end-tidal CO2 reading falls from 40 to 30. You remove the patient from mechanical ventilation and start doing bag valve mask or hand ventilation. But the condition does not change. A suction catheter is rapidly and easily passed beyond the tracheal tube, does not meet resistance. Which of the following causes of acute deterioration of the intubated patient is most likely to be present? Is it displacement of the tracheal tube out of the airway, obstruction of the tracheal tube, pneumothorax, or equipment failure? And why do we say that?
He doesn't have any breast cells on the right side. His stats are failing.
So sats are dropping and no breath sounds on the right side.
But the catheter passes easily, so there's no obstruction.
So the catheter passes easily, there's no obstruction. And what about displacement of the tracheal tube out of the airway?
CO2.
You have an end-tidal CO2 reading, okay? So this is where, you guys are familiar with the DOPE mnemonic, D-O-P-E? You may or may not be, but this is a nice thing to think about when you're finding yourself in a circumstance where you're not sure what's going on. So the correct answer is C. The causes of acute deterioration of the intubated patient are recalled by the dope mnemonic. And the dope mnemonic stands for displacement, obstruction, pneumothorax, or equipment failure. So pneumothorax, especially tension pneumothorax, is the most likely possibility in this case. It occurs more commonly on the right side than the left side because the right side is where the tracheal tube will go if it slips in a little far, so you get right main stem intubation. And that can result in overdistension of that lung and create a pneumothorax. Questions about this? Does that make sense to everybody? All right. So we just climbed the mountain of respiratory physiology. When my wife and I were hiking on the Appalachian Trail, we started out down where that bridge was, then we climbed up. I don't know if you see, anybody ever hiked the Appalachian Trail? Just as an aside, you see these little white marks? See the white mark on there on the rock? The Appalachian Trail has white marks that are marked off every so many paces. And all you do is follow the white line. And as long as you follow the white line, you don't get lost. And it goes for 2,200 miles. Questions about that?
No thanks.
Why?
That's planning on doing that Saturday or something.
Yeah. Just follow the white line.
Saturday or something.
Yeah, it usually takes like really fast, really in shape people about 3.5 months to do it.
Oh, I'm good then. I'm still good.
I'm ready to go work, but then.
So what's a mechanical ventilator? A mechanical ventilator is a machine that does the job of breathing for us. There are different ventilator modes. There's control modes, assist control modes, and intermandatory ventilation modes. The control modes are where volume control is where we deliver a specific targeted amount of volume. And we deliver that by positive pressure to the lungs. And whatever pressure it takes to deliver it is what the ventilator will keep pushing gas until it gets that volume delivered. Unless you have a pressure limit set on it, which we set on most of our ventilators. So you set the rate, the tidal volume, the IDE ratio, the PEEP, and the FiO2. And then the PIP is dependent on the resistance or compliance of the lungs. We know that there's a pressure volume relationship in the lungs, so we call that compliance. Compliance is equal to the volume divided by the pressure, or delta V over delta P. If you blow a fixed amount of air into a stiff balloon, the first time you blow up a balloon, it's really hard to blow it up, right? And your cheeks puff out and they hurt. You got to keep blowing it. And finally it gives. And then once it gives, it blows up easily. So if you blow it up and you let the air out, you blow it up and let the air out, about 10 minutes in, the 11th time you blow it up, it's really, really easy to blow up. And that's the way our normal lungs are. It's like blowing up a balloon for the 10th time. When compliance gets bad, that's what it's like when you try to blow it up for the first time, where there's a lot of resistance to your flow. Okay. And that's the relationship that we look at when we use a mechanical ventilator. In a volume mode where you set the volume, the pressure is going to vary and it puts you at risk for what? Baritone. Because you're setting the volume. So when you set volume, it puts you at risk for baritone. And so you have to worry about that and you have to track it. Pressure control is a mode where you set in pressures and you tell the ventilator to keep delivering flow until you hit a certain pressure. And it will keep delivering flow until it hits that pressure. Okay? Doesn't matter how much volume you're giving. And therefore, you're at risk for volume and volume-induced injury. All right? And so we do have safety measures that are built into the ventilators to protect you from doing that too much, but you set those too. And so you set your safety targets. And you have to be aware. I mean, I always tell people, you know, a ventilator is just a machine. It's the person that sets it that actually regulates what it does. You can have it do whatever you want it to do, but you have to know how to set it properly. All right, so these are different settings that we can set on the ventilator, and these are effects it's going to have on your PO2, your PaO2, and your PaCO2. So if you increase the rate, the increase of the rate is really not going to affect your PaO2. But increasing the rate will increase the minute ventilation as part of the equation for minute ventilation, and therefore it will drop your PaCO2, and therefore will raise your pH. If you're in a volume mode of ventilation and you increase the tidal volume, you're going to increase your PaO2. Why?
Because you're getting more volume in and more oxygen is going to be able to cross the alveoli.
More surface area by more volume.
Sorry?
More surface area by more volume.
So the reality is that by giving more volume, you're actually going to alter the pressure, right? Because the compliance relationship says that if you change delta V, you're going to change delta P. If you're changing delta P, you're going to be exposing more pressure to the alveoli, and therefore you're going to drive gas across. So it's because of compliance. If you were in a situation where there was unlimited compliance and you could keep giving volume and it would never change the pressure, you wouldn't drive that gas across that interspace. Seconds. But in a situation where you've got compliance, then anytime you increase your delta V, you're going to increase your delta P. It's not going to be an exact increase. If I increase delta V by 50%, it's not going to increase delta P by 50%. But it's going to increase delta P because they're proportional to each other. And therefore, you're going to improve your pressure, and therefore, you're going to drive more gas across. Because remember, the only two things that drive gas across, concentration gradient, pressure gradient. So you're increasing your pressure gradient, right? So if you increase your tidal volume, you're increasing your delta P, therefore you're increasing your pressure gradient and you increase your PaO2. If you increase your tidal volume, you're increasing your minute ventilation because it's part of the equation. Respiratory rate times tidal volume equals minute ventilation. Therefore, you're going to drop your CO2. If you increase your PIP, you increase your PaO2 because increasing PIP increases the pressure gradient across the alveoli. If you increase your PIP, you're going to decrease your PaCO2. Why is that? Because by increasing PIP, you're increasing your delta P. As long as you don't increase your PEEP, you're creating a bigger change in pressure. Therefore, you increase delta P, you increase delta V. If you increase delta V, that's like increasing your minute ventilation. And therefore, you're going to increase your minute ventilation. You're going to exchange gas better. So you're going to drive your CO2 down. You're going to drive your pH up. Questions about that? And that's, again, because of compliance. Questions? Everybody's good?
No, I understand.
Delta.
Yes. So delta is difference. Okay? So if you have a PIP and you've got a PEEP, the difference between those two is equal to delta P, or change in pressure. So this just is change of difference. And so if you increase your PIP, but you keep your peak the same, so if my PIP goes from 20 to 25, and my PEEP stays at 5, then my delta P is going to go from 15 to 20. And if I increase my delta P from 15 to 20, then I'm going to increase, because we know that delta P is directly proportional to delta V, tidal volume. So tidal volume and delta V are the same thing. Those are equal to the same thing, just change in volume. So if you increase your delta P, if you increase this, you're going to increase your delta V, and therefore you're going to increase your minute ventilation, because minute ventilation is equal to respiratory rate times delta V, or respiratory rate times tidal volume. It's the same thing. All right. I use delta V because tidal volume is a setting on the ventilator, and I don't want people to think that that's the only way you can do it. So it's really a delta V, or a change in volume. Okay.
How do you increase your PIP? Usually that's based off of patient's lung compliance.
So it depends on the ventilator, and it depends on whether you're using a pressure-driven mode of ventilation or a volume-driven mode of ventilation. If you're using a pressure-driven mode of ventilation where you're changing your pressure control, so pressure-driven modes of ventilation are like pressure control. So if you increase your pressure control, you're either going to be increasing your delta P, or you're going to be increasing your PIP, depending on which ventilator you're using. Because different ventilator companies have different ways of doing it, and they patent all their different ways. But the important thing to remember is that pressure control, depending on which ventilator you're working with, may actually be increasing. If you increase pressure control, you may be increasing your delta P, okay, or you may be increasing your PIP, okay? And that does make a difference in your delta V. And it makes a difference because if you're increasing your delta P, because delta P is equal to PIP minus P, if you increase delta P, it's going to be different than if you're increasing your PIP. Okay?
Okay.
And the ventilator that you set this on is the Draper. So when you set pressure control on the Draper ventilator, you're actually setting the PIP. Okay? All the other ventilators, when you set pressure control, you're setting a delta P.
Okay.
And that's just the ventilator, and you just have to know the ventilator you're working with. I mean,
So
so
basically what you're saying is an increase in pressure equals an increase in volume.
an increase in change in pressure equals an increase in change in volume.
But doesn't an increase in pressure also increase your volume?
Not if you increase your peak. So if you increase your PIP
Right,
and you increase your peak the same amount, your
Right.
delta P is not going to change.
But if we're
And
not
therefore your
talking
delta
about-
P is not going to change, right?
Yeah.
But that's where it makes a difference, whether you're talking about which ventilator.
Yeah.
Does that make sense to everybody? Yeah? Okay. And again, it's the craziness of the ventilator companies. You just have to be aware. When I go into a new ICU and a ventilator I've never used before, the first thing I do is read about the ventilator. And what does it mean when I set pressure control? Am I setting my PIP or am I setting my delta P? Okay. All right. And then let's see, so we're down to PEEP. So if you increase your PEEP, you're going to increase your PaO2 because you're going to increase your mean airway pressure, right? Because the equation for mean airway pressure. Do we want to talk about that? Yes, no?
Yes, yes,
Yes. All right.
yes.
Okay, more equations. So mean airway pressure is equal to the I time times the PIP plus the E time times the PEEP divided by the I time plus the E time. Okay, now I know this sounds complicated. Let's do a practical example. I like practical examples, okay? I also like things that show up. So if you're in this, when I say I and E, it can be your I to E ratio, not just necessarily your I time to E time. So I like to think of it as the I to E ratios. So a normal I to E ratio is about 1 to 3. Yeah? That's when we normally breathe. We breathe about a 1 to 3 or 1 to 2. If our normal PIP is going to be, let's say our PIP is at 20 and our PEEP is at 5. Okay? So it's going to be 1 times 20 is going to be 20 plus 3 times 5 is going to be 15 divided by 1 plus 3 or 4. So 45 divided by 4 is going to be about 11.25. I hope. Okay, now what happens if I change any of these things? Now we're talking about PEEP right now, right? So let's say that we change our PEEP from 5 to 7.
And increase your back. Here, here.
Okay, now it becomes 20 plus 21 divided by 4. And now it's going to be 40 divided by 4. I did math wrong. You guys are not,
That's what I was saying.
35 divided by 4 is going to be like 8. 8 and
Dude, you gotta fact check it from here on.
3/4. Right? I told you I made it. Right, is this right? I don't have, I don't have. This one,
That's
no.
right.
And this one is going to be 10.25. Sorry about that. So what we've done and all we've done is we've changed our PEEP from 5 to 7. That's all we've done. And we've increased our mean airway pressure from 8.75 to 10.5, or by about 2. Okay. And so that's going to increase your oxygenation. That's going to help you oxygenate better. Does that make sense to everybody?
Yeah.
Okay. All right. So we're going to leave this equation up here because it's going to become important when we talk about others. Now, if we increase our PEEP, what does it do to our CO2, or what does it do to our minute ventilation? Well, this is where it becomes really important to know what kind of mode you're in. Okay? If you're in a volume mode of ventilation and you increase your PEEP, are you going to be affecting your delta V or your tidal volume? No, because you're in a volume mode of ventilation, you're setting the volume. Therefore, you're not going to change your minute ventilation. Therefore, you should not change your CO2 exchange. Does that make sense? All right, now if you're in a pressure mode of ventilation, it depends on whether you're in a delta P pressure mode of ventilation when you set pressure control, or a delta, or if you're in a PIV mode. Now, why do I say that? Because delta P equals PIP minus P. And if you're setting your PIP, okay, your PIP is 20 and your PEEP is 5. If I don't change my PIP, okay, if I'm on a Draeger ventilator and all I do is increase my PEEP from 5 and I increase it to 7, what's going to happen to my delta P? It's going to go from 15 to 13. My delta P is going to drop. If my delta P drops, what's going to happen to my delta V? It's going to drop because it's directly proportional. Therefore, what's going to happen to my minute ventilation?
It's gonna drop.
It's going to drop. And my CO2 will go up. Okay? Again, this is only with the Draeger ventilator. So you just have to be careful when you're using Draegers. If with a Draeger, if you want to increase your peak from 5 to 7, you have to increase your pressure control from 20 to 22. To keep, and you increase it by the same amount you increase your peak to keep your delta P the same. All right? Any other ventilator that you use, any other ventilator except for the Draeger, when you set pressure control, this is your pressure control here. And so it doesn't matter what you do to the peak because your delta P is going to stay the same. Okay? So the only ventilator that's an outlier is the Draeger ventilator. That comes with ventilators because that's the way they do the pressure control. Questions about that? Okay, so this is probably one of the hardest things to think about because we're used to ventilators always being the same, and they're not. Okay, if you increase the FiO2, it's obviously going to improve your oxygenation, but it's not going to affect your ventilation. And then lastly, when you look at your I time, if you increase your I time, what effect does that have on your oxygenation and ventilation? Well, let's go back to our equation here. If you increase your I time, so you go from a 1 to 3 to a 1 to 1. All right, let's take your peak back to 5 here. Let's get rid of these two equations. You guys check my math, all right? All right, so if our I time, our IDE ratio is 1 to 3, it's going to be 20 plus 15 divided by 4, which we said was 8.75.
It would be 5 by 4.
1 plus 3, I plus E right now.
You change it to a 1 to 1.
Change it to 1 to 1.
I'm going to change it to 1 to 1 now, but I want you to see where it is first, okay? Because I want to show what changing your IDE ratio does, okay? So double check my math. 35 divided by 4, 8.75, right? Okay. Now let's change it to a 1 to 1. So we change our E to a 1. So we've now made our IDE 1 to 1. Now we're at 20 plus 5 divided by 2. And we're up to 12.5. So you can see by simply changing your IDE ratio, you can dramatically increase your mean airway pressure, which is going to do what? It's going to dramatically improve your oxygenation. Okay? All right? And so that's why I time will improve your PaO2. Now, what does I time do to CO2 or to minute ventilation? Well, this is where it really depends on whether or not you're able to reach end exhalation. If you can reach end exhalation, it's not going to make any difference at all because you're not changing your tidal volume and you're not changing your respiratory rate. The only time it can be a problem, and that is an error in this slide, and I apologize. This should be just a slash. It has no effect. As long as you can reach end exhalation. And we'll talk about how you can tell if you're going to reach end exhalation a little bit later. Okay? Questions about this? Questions about the I time issue? Okay, so when we start talking about the ventilator, then we have to start talking about complications. Machine malfunction, pneumonias, tracheal stenosis, decreased cardiac function on high settings. Now, of these, the only ones we really need to worry about is this one down here at the bottom. Okay, because if you use too much pressure Okay, then you can impede your venous return to the heart, and therefore you can cause hemodynamic instability. And we'll talk about that in a minute. Toxicities of mechanical ventilators we already talked about. We talked about already what our goals are going to be. So our goals are going to be get your FiO2 less than 40 to 60%, tidal volume 6 to 8, your PIPs less than 35 to 40, and your MAPs less than 20 or 25. And then you can avoid most of the toxicities of the mechanical ventilator. We've talked about this to an extent. When we're trying to improve oxygenation by raising mean airway pressure, we can do it by raising the PEEP. And typically we raise PEEP by 2 at a time. Most of the time when we get our donors, they're going to be on a PEEP of 5 to start with. We take them from 5 to 7 to 9 to 11. I usually take them up to about 12. You know, where you take them from 5 to 8 to 10 to 12 is what I usually tell my folks to do. That helps to improve their mean airway pressure, helps oxygenation. The other thing I do is I take my I time out to a 1-to-1 to start with, and that raises my mean airway pressure significantly immediately. And as long as I'm reaching end exhalation, I'm in a safe place. Okay. Now, how can you tell whether you're reaching end exhalation or not? So this is one of the graphics that you see on a ventilator on the main screen of the ventilator. It's called the flow time curve. And the flow time curve is really an important curve to look at, especially when you're talking about taking people out to an IDE of 1-to-1. So what you want to do is you want them to come to full exhalation. So you want them to get all the way back up to baseline of 0 before they get the next breath. So this is a breath in, this is exhalation, this is full expiration. They're reaching their 0 baseline, then they get their next breath. If they're not coming all the way back up to baseline, they're having incomplete exhalation, they're air trapping. If they're air trapping, you cannot keep them in that position, because that creates a situation where they're either going to be, because of the way you set the ventilator, they're going to be pressure limiting, volume limiting, or they're going to be creating a pneumothorax. Okay. And these are the patients that you cannot invert into a 2-to-1 ratio. You can't do inverse ratio ventilation on these patients. In fact, you have to back off till they reach end exhalation. And the likely explanation is there's either a plug in there, or more likely they've got some kind of chronic lung disease. And they're just not able to fully exhale. They've got COPD or something like that. So even if their CT scan doesn't show COPD, if you start seeing them not reaching complete exhalation at an IDE of 1-to-1 at a low rate. Now, when I'm talking about a low rate, I'm talking about somewhere between 12 and 15 is typically where I like to get them to. But if their rate's down at 12 to 15 and they're not reaching end exhalation, then they're unlikely to be, they're not going to tolerate an inverse IDE ratio, and they likely have some kind of intrinsic lung disease. And they're not going to probably be a lung donor. Okay. Does that make sense to everybody? So this is usually that middle graphic, and it's called the time flow curve. And I get more information just looking at this time flow curve than I do of almost anything else when I'm doing ventilator manipulations. Now, if I do reach end exhalation, but I'm still not oxygenating the way I want to, then I'm happy to flip them into an inverse ratio ventilation. Questions about that? Everybody understand that one? And you know that curve, you've seen it? You know it, you love it, you've seen it. Okay. Talked about oxygen delivery already. We've talked about consumption. We've really talked about volume control, pressure control. So PRVC is pressure regulated volume control. It's a volume control mode where you set a tidal volume, but it's delivered as a pressure control waveform. So it's a decelerating flow waveform. So decelerating flow waveforms give you a higher mean airway pressure and a lower peak pressure for the same amount of tidal volume. So if you take somebody that's on volume mode of ventilation and you compare them to somebody in a pressure mode of ventilation, and you have them on exactly the same delivered tidal volume, their peak pressure is going to be lower and their mean pressure is going to be higher in a pressure mode of ventilation because it's delivered by a decelerating waveform. And all that PRVC does is it automatically does that for you, except you set the tidal volume. The difference between PRVC and pressure control modes of ventilation is in pressure control modes of ventilation, you have to adjust your pressure control or your delta P in order to deliver the tidal volume target you want. In PRVC, you can set the tidal volume the way you want it, and the ventilator will automatically adjust the pressure. So that's a good thing and it's a bad thing, because the reason it's a bad thing, the reason I don't use a lot of PRVC is because I generally want to try to recruit lungs and I want to try to recruit them quickly. In PRVC mode, whenever the lung compliance starts to improve, the ventilator automatically turns the pressure down. So it takes a lot longer to recruit. If I leave them in a pressure control mode of ventilation, then I will let them get up to a tidal volume instead of 8 per kilo. I'll let them get up all the way up to 9 per kilo before I start turning them down. That way they've got more expansion, they've got more recruitment, and it's quicker. So I don't use PRVC in my donors for that reason. But if you're not going to use PRVC, you must pay attention to the tidal volume. Because that tidal volume, as the compliance improves, will start climbing and climbing, and you can end up in a situation of volume drop. Questions about that? Everybody got that concept? Yes? Okay, moving on. Now, I throw this in there because the high frequency oscillating mode of ventilation is probably, in my mind, would be one of the best modes you could use for a donor. Because basically you set a mean airway pressure and you just leave it, and then they just recruit. The problem with it is I don't know of any lung program in the country that will accept lungs off of a high frequency oscillating ventilator mode.
That way.
Because we think about high frequency oscillating ventilator modes as the last ditch effort. And so they think the lungs are terrible, as opposed to we just need to really recruit them as quickly as we can. So we don't use the mode, but I bring it up because I think if we could use it, it probably would be a really good mode. All right, and that's the end of this part of it. We've come to the end of this railroad track. And we're going to stop this talk here, and I'm going to answer any questions if I can.
Say you take your peeps from 5 to 7 to 9, like how quickly do you do that?
So I do it pretty quickly. I usually tell my folks that within the first 2 to 4 hours, they should be up in their peeps 12. So I go from 5 to 8, 8 to 10, 10 to 12. I'll do it every 30 minutes to an hour. I won't check blood gases. I'll look at my end tidal CO2s. I'll look at my saturations. And then I'll get a blood gas at the end of getting them up to a peak of 12. And I take them out to an IDE of 1-to-1. So I take all my patients from volume control, I take them all over to pressure control. I target 8 cc's per kilo of tidal volume based on their ideal body weight. I won't turn them down unless they get up above 9 per kilo. I won't turn them up unless they get down below 7 per kilo on the pressure. And then I just give them time. But I will turn the PEEP up by 2 at a time every 30 minutes to an hour, as long as they're hemodynamically tolerating it. Okay? Because the one thing that you have to worry about a little bit when you increase your I time out to a 1-to-1 and you start increasing your PEEP, you start increasing your mean airway pressure. And when you get your mean airway pressure up too high, you start to impede venous return and your patients can become a little bit hypertensive. And most of our donors, as you know, to begin with are hypertensive. So usually what we do is the first thing we do is we give them 500 milliliter of volume. Then we start doing all the changes with the ventilator. But I don't wait for blood gases because I don't really care what the blood gases are until I get up to that PEEP of 12, IDE of 1-to-1, pressure control mode of ventilation with a rate somewhere in the mid-teens. And then I worry about the blood gases. That's why I like to use the end tidal CO2 because it allows me to make these changes quicker and I don't have to wait for blood gases to come back. Questions? Other questions? All right, so this is kind of what I would call the basics of mechanical ventilation and understanding blood gases and a little bit of the respiratory physiology. And then what we'll do now is I don't know if you want to take a minute and stretch or what you want to do, but I think maybe get up for a minute, grab your legs, and then we'll get on to the next topic. All right, and if you have questions, by all means, again, ask.